chest thoracic system. And graciously, we have someone who's volunteered. In the military, we say never volunteer. Yeah. For this, you need to have not only your stethoscope, but you need to have a measuring tape and a pen. So I'm going to ask you to face this way. Sit down here, facing me. Okay, so the first thing I'm going to do is ask my client to relax, put their hands inside, and I'm going to be looking at the spinal column. It should be midline. There should be no sign of scoliosis, which is an S curve. There should be no signs of lordosis, which would be down in the lumbar area, or kyphosis, which we see in elderly people in the upper thorax area. I'm also looking to make sure the scapula, top of the scapula, is straight. So you need to make sure your client is sitting up, not slumping over. No, that's all right. You're doing fine. Then I'm also looking at the skin color for any lesions or moles. If I see one, I'm going to ask my client and palpate it. Do you know you have a mole right here? Because a lot of times we don't know what's on our back. And you might want to make sure that the person is being followed by a dermatologist if they have a mole. Okay? So you want to indicate where you see that. The skin coloring is good on him. Then the next thing I want to check is the distance or the ratio of the anterior posterior thorax with the transverse. So I'm looking at from the side this time. No, just relax. AP should be less than the transverse. Transverse is almost twice the size of anyone's AP. So you can just put transverse greater, you know, the greater sign than AP. People with emphysema often have a barrel chest, which is going to change that ratio because the little air sacs inside are blown up like little balloons and they push the chest wall out. But his transverse is greater, the greater sign, than his AP. Okay? The next thing I'm going to do is auscultation, which is probably maybe different than what Jarvis has you do. And the reason I do auscultation next is if my client has any adventitious breath sounds, God bless you, which would include crackles, which in the past were called rails, if he has any gurgles, which were called ronchi in the past, or wheezing. If he takes some deep breaths, crackles or rails are called discontinuous sounds, which means that at one point I might hear it, then I call you over to substantiate, and you say I can't hear anything, because he's been taking deep breaths and they've gone away. Okay, or gurgles or ronchi are continuous, they won't go away with deep breaths. Wheezing, the same thing. Okay, so I'm going to listen in 6 areas. I'm going to tell my client to breathe in through his nose, out through his mouth, a little bit harder than he normally would. So I'm going to listen between the scapula first. Go ahead, take some breaths for me. Good. Again. I should be hearing vesicular breath sounds throughout. Okay, that's what the normal should be. Below the scapula, again. Good. Now under each axilla, just relax. Good. One more place. Good. Just relax. So I should hear vesicular breath sounds in all 6 spots. So I could document vesicular breath sounds heard throughout. Next, since I have my stethoscope out, I'm going to skip and go to egophony. Once you've auscultated, you can go through any of the steps. They don't have to be in order. The first thing is you want to make sure you auscultate.
I'm sorry, can you show those 6 points where you auscultate?
Yeah, you don't have to breathe, I'm just going to move. Yeah. Between the scapula, below the scapula, and under each axillary area. Okay? I know Jarvis has about 20 different places. The problem with that is that people get lightheaded, even young people. So you can hear what you need to hear in 6 spots. But spend some time listening at each spot, the inspiratory cycle and the expiratory cycle. Don't just move it around and hope for something, okay? Next is egophony, where you're going to ask your client in the same 6 spots to say the letter E. It should sound like E. If it sounds like an ah sound, like Fran Drescher, do you remember her? Okay, she has like a nasal quality. That's an indication that maybe there's some consolidation, mucus building up in the lungs. Okay? So you should hear the E sound. Are you ready? Good. Negative egophony. Okay. Next I'm going to do tactile fremitus. And this is where I'm feeling when he says 99 for vibrations. When I touch up here, there's not much to stop the vibrations, is there? There's no organs up here. As I move my hand further down, what will interfere with the vibration? What organ? What muscle?
Diaphragm.
Diaphragm, okay? So if I know as I put my hand further down here and I feel the vibration heavier than it should be, then I want to indicate positive tactile fremitus below the scapula or wherever I'm feeling it. Because again, that's not normal. It's another sign of consolidation or mucus building up. Okay, say 99.
99.
Okay.
99. 99.
So tactile fremitus is WNL. What is that?
With analysis.
Okay. All right. The next thing I'm going to do is thoracic expansion. I'm going to put my thumbs together with a little bit of his skin in between. And I'm going to ask him to take a deep breath in and out. And I'm looking for some movement of my thumbs. And I'm feeling with my fingers so that the expansion is symmetrical on both sides. Okay, go ahead. One more time. You can see the, okay, good job. He has equal or symmetrical thoracic expansion. Okay? All right, I also wanted, do you have any questions? Stop me rather than talking with each other. Okay, I'm going to do percussion next, and I'm comparing one side of the body to the other. Oftentimes students have problems with this because they're only using one finger, they haven't been practicing. You got to put your ear close. So follow what I'm doing. I never really take my hand off of his thorax. Comparing one side of the body to the other till I hear dullness, which I'm hearing now. So up here is resonant sound. The diaphragm stops it, so it becomes dull. I stop.
How do you strike your hand? I want to see that.
Yeah, can I?
Because that was really good.
Yeah.
Okay. Well, let's see if we do it here. All your other fingers have to be up. You hit with 2 fingers.
Okay. Okay.
Practice that. Practice. You know, I used to have students when I taught health assessment go around the room. They hated it, but you know, it's like looking for where you're going to put a nail in the stud. Okay? You want to make sure all your other fingers are up, because if they're down, they're going to stop the vibration. Make sure your nails are short so you don't hurt yourself or the patient. Use 2 fingers to tap. Then the trick is you're comparing one side to the other, so you're never really taking your non-dominant hand off of the back of the thorax. Put your ear there so you can hear. You should hear a resonant sound. If it's a hyperresonant sound, indication of lung disease like emphysema, COPD. Okay? All right. Next, I'm going to do diaphragmatic excursion. The trick with this is knowing where the diaphragm is during inspiration and expiration. When you breathe in, the diaphragm contracts downward, so it's going to be lower. When you expire, the diaphragm relaxes, pushing the waste products out. So what we're looking when we're doing diaphragmatic excursion is where the diaphragm normally is during expiration and inspiration. The way I remember doing it, which one first, expiration or inspiration, in my alphabet, E comes before I. So I always know I've got to do the expiration part first, followed by inspiration. So what I'm going to have my client do, don't do anything yet, is he's going to breathe normally, take a breath in, and blow it out as completely as possible. And I'm going to start percussing from about where the scapula is, where there's resonant sound, to dullness. I'm going to stop, tell him to breathe, and I'm going to mark it with my pen. Okay? Then I don't have to start up quite as high, because during inspiration, where is your lungs?
Expands more, so they're like, is that what you mean?
What position is the lung going to be, up here or down here during inspiration?
It's like up
No. That's why you got to understand what you're doing before you do it. I could teach anyone the technique of doing diaphragmatic excursion, but you're all professionals, so you need to know why you're doing it. Let's look at that again. During inspiration, and memorize it until you get in your head. During inspiration, the diaphragm contracts downward so the lungs fill up. The diaphragm is going to be here, down here. During expiration, the diaphragm relaxes and it will be up here, pushing up. Okay? So we're going to do expiration first. All right, so take a deep breath and hold it. Blow it out and hold it. Good. Breathe. And I want to mark this with a pen. Okay. All right. Now this time I want you to take a deep breath in and hold it. I'm just going to go a little bit above this line. Breathe. So I'm marking where it goes from resonance to dull. Remember, during expiration, we expect the diaphragm to be where? Up higher, right? During inspiration, lower. So we do expiration first, then inspiration. When you do for inspiration, start just a little bit above your line here. You don't have to go all the way up to the scapula. We're going to do one on the other side. Again, take a deep breath, blow it out, and hold it. Breathe. You're closer. Can you hear the change in sound? Mm-hmm. Okay. Next comes inspiration. I want you to take a deep breath in and hold it. Breathe. All right. These will be permanently there. You know, you didn't want a tattoo, now you got it. Normally in an adult, you use a centimeter portion of your tape measure. Should be between 3 and 5 centimeters. But really what we're checking for is to make sure it's pretty even on both sides. We don't want it up here on one side and down here on the other. So his is about 3, you see? Mm-hmm. A little less than 3, but pretty good. Have I done everything on the on the thoracic? Yeah. Okay. I want to thank you. And yes, it will come off.
Oh, okay.